Now we're going to solve is anatomy question paper of first terminal examination at Naraina Medical College Kanpur, and this is part 2. So the long question here was a structured long question on the shoulder joint. Describe shoulder joint in the following headings: structure and ligaments of 5 marks, movements with the performing muscles. This is important. You should mention all the movements, and those movements are being caused by what muscles. You have to mention them. This is really important because there are all the movements possible at the shoulder joint: flexion, extension, adduction, abduction, medial rotation, lateral rotation, and circumduction. All these movements are being performed by which muscles? You will have to mention this. And then including the clinical anatomy, the frozen shoulder, caries sicca, subacromial bursitis, Dauburn sign, then aspiration of the synovial fluid sometimes. All you can mention here in this. Then 5 marks short notes. As I already told you, you will have to restrict your answer to a maximum of 500 words. The questions here were femoral triangle. You can easily describe this triangle. It's a very super important question. So femoral triangle, then arterial anastomosis around the scapula. This also is very important. Remember, it's the bypass circulation from the first part of subclavian to the third part of axillary artery that you should mention in this. Remember, in all of these questions need not be asked. You always have to draw maximum diagrams in support of your answers. Anatomical snuff box is also super important question. Make sure you know this. Then writing down the ultra short questions. These were 5 questions of 2 marks each. And remember, the maximum you can write here is up to maximum 100 words in this. In this ultra short question, first was about the saddle joint. Remember, the two reciprocating concavo-convex surface form this joint, saddle joint, multi-axial joint. And the best example you must be knowing is the first carpo-metacarpal joint, sternoclavicular joint, patellofemoral joint. I just explained in one of the MCQs before. Then the joint between malleus and incus, incudomalleolar joint. And don't forget the calcaneocuboid joint in the skeleton of foot. Attachments at the lower and the humerus, super important question. I told you there are very much chances they can ask the questions from osteology as well. Phalen test is related to carpal tunnel syndrome. So this is how Phalen's test is performed in carpal tunnel syndrome by touching the dorsal surfaces of both your hands and making the maximum flexion possible at the wrist. So by doing this, you are actually checking for the signs and symptoms, especially the pain arising due to compression of median nerve in the hand that is undergone this carpal tunnel syndrome because of the compression of median nerve, right? Then patella. It's a 2 marks question, and all you need to write here in patella, I have already explained in one of the MCQs above, the 8th MCQ in the above part 1 question paper. Saturday night palsy, it's a compression of the radial nerve in the radial groove, and it's a neuropraxia type of injury which is a transient compression of the nerve, loss of sensory impulse conduction, sensory as well as motor impulse conduction is lost, and that's why there is numbness as well as there is wrist drop. Sensory and numbness will be along the distribution of the radial nerve, that is in the dorsum of the hand on the lateral half. That's the area overlying the anatomical snuff box as well. In case if it's asked what will be the answer for finger drop, which nerve undergoes compression and leads to the finger drop deformity, the answer will be posterior interosseous nerve of forearm. Now talking about MCQs here, sorry, it's a misprint here actually. This is actually question number 3. and this will be question number 4. Now let's start solving these MCQs of paper 1 part 2. Question number 1. All of the following arteries supply the mammary gland except subscapular artery, thoracoacromial artery, lateral thoracic, intercostal. So here you're seeing is the arterial supply of the breast. You can very well see the blood supply from above. Those are the branches from axillary artery. One is superior thoracic artery. Then you have is an acromiothoracic artery through its pectoral branch. Now this is pectoral branch of thoracoacromial artery. Then you have is the lateral thoracic artery. Then you have laterally the branches from the posterior intercostal arteries, and from the medial side it is the perforating branch of the internal thoracic artery. 2 to 6 is the vertical extent, so it will be mainly 2, 3, 4, 5, 6 intercostal spaces where these anterior and posterior intercostal arteries, they will supply branches to supply the breast from the medial and lateral sides. So in this image, what you are not seeing is the answer, and that is subscapular artery, which actually is running along the lateral border of the scapula. It actually reaches down in the back along the lateral border of latissimus dorsi, under to the cover of latissimus dorsi in the form of thoracodorsal artery. So here in this MCQ number 1, the answer will be subscapular artery, which actually is the largest branch of axillary artery. Question number 2, following structures form the boundaries of the apex of axilla except clavicle, upper border of the scapula, outer border of the first rib, deltoid muscle. Here in this image you are seeing is apex of axilla and the boundaries of the apex of axilla. So posteriorly you are seeing is the superior border of the scapula that forms the boundary above, and it is anteriorly the posterior surface of the clavicle, the middle one third, and medially it is the outer border, the first rib. So these three bones, they form the boundaries of the apex of axilla. You know, actually axilla is a truncated pyramid, right? So it doesn't have a pointed apex. So answer to question number 2 will be the deltoid muscle. Question number 3, Klumpkeys palsy, the lesion involves is C5, C6, C7, C5, C6, C8, T1, C7, C8, T1. A very important and very simple, easy question. This you're seeing is brachial plexus, and all these roots are actually the anterior primary rami of these spinal nerves. And the site of injury in Klumpkeys paralysis is this, the lower trunk of brachial plexus. And the spinal segments contributing to this lower trunk are C8 and T1. And these C8, T1, they run along the medial cord of the brachial plexus through its anterior divisions into the medial cord and through its posterior divisions into the posterior cord. But through the posterior cord, these segments C8 and T1 reaches only up till the dorsum of the hand in the form of cutaneous distribution to the superficial branch of the radial nerve. That is the cutaneous area overlying the anatomical snuff box and the lateral half of the dorsum of the hand. And through the medial cord, it gives out branches, the medial pectoral nerve, the medial pectoral nerve, medial cord of brachial plexus, medial root of the median nerve, then medial root of median nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and finally medial cord continues as ulnar nerve. So, talking about Klumpkeys paralysis, remember that's a complete claw hand. The reason being the 20 intrinsic muscles of the palm, out of that 15 intrinsic muscles are being innervated by ulnar nerve, including the third and fourth lumbaricals. While remaining five intrinsic muscles, they are innervated by the medial root of median nerve that includes the AFO, abductor, flexor, and opponens pollicis brevis of the thenar eminence, as well as the first and second lumbaricals. So when all these 20 muscles are paralyzed, basically when we talk about claw hand, we are considering the 12 muscles, the 4 lumbaricals, 4 palmar and 4 dorsal interossei. So these 12 muscles, when they'll be paralyzed, they'll be a complete claw hand. Remember that. While out of these 12 muscles, only 10 muscles are being innervated by ulnar nerve. First and second lumbaricals are spared if we're talking is about the injury of ulnar nerve in the Gwen's canal or injury of ulnar nerve at the wrist. So at that time, 10 out of these 12 muscles will be paralyzed. First and second lumbaricals will be spared. And that's why, due to ulnar nerve injury at the wrist, there will be a partial claw hand or ulnar claw hand. The clawing on the index in the middle is relieved, is little but released. So that's why remember this the difference between ulnar claw hand, which is a partial claw hand, and in Klumpkeys paralysis, there is a total claw hand deformity. So answer here is Klumpkeys palsy. The lesion involves is spinal segment CAT1. Question number 4. Overhead abduction at the shoulder joint is caused by deltoid, supraspinatus, deltoid and supraspinatus acting together, trapezius and serratus anterior acting together. So in this image, what you're seeing is the muscles involved in lateral rotation of scapula. This you are seeing is insertion of the upper fibers of trapezius. And here you're seeing is the insertion of the lower fibers of trapezius. Can you appreciate the attachment of serratus anterior marked in this image? They have shown is in dotted lines. Means what? They're trying to show that this is not on the dorsal surface. So this is on the costal surface of the scapula. This is the insertion of lower 5 digitations of serratus anterior. The upper 3 digitations, they are on the medial border costal surface of the scapula. Those upper 3 digitations of serratus anterior are meant for the protraction of the scapula. But the lower 5 digitations which are inserted onto the inferior angle of the costal surface of the scapula, these you can see are meant to pull the lower end of the scapula, and trapezius, the upper fibers, they're attached to the clavicle as well as on the medial border of the acromion. They pull the scapula above, they elevate the scapula as well as pull it medially, upwards and medially. And that's why remember that trapezius, that's why it's called the shrugging muscle of the shoulder joint. While the lower fibers of trapezius, trapezius arises from the external-occipital protuberance, ligamentum nuchae, then supraspinous ligaments from the spines of all the 12 thoracic vertebrae. So the lower fibers of trapezius, they're inserted here, it has a wide insertion like this, fibers reaching down till here to the root of the spine of scapula. So the lower fibers, when they'll contract, they will pull this superior angle. This is the superior angle of scapula. They pull it downwards and medially. This is superior angle is pulled downwards. So that's how together you find the two muscles, trapezius and serratus anterior. They help in the lateral rotation of the scapula. But there's one more factor which is involved, which you should know, and that is the lateral border of the scapula. You must have felt and palpated scapula several times. you'll find that this lateral border of the scapula is very thick and cord-like. It acts actually as a leverage, right? So this is really important in the lateral rotation of scapula. Remember, if this is fractured, what will happen? The blade scapula is fractured. So upper portion of the scapula will be elevated above while the lower portion of the scapula will be pulled forward. And what will happen that there will be no proper lateral rotation, or you can say that this overhead abduction of the arm will not be possible if there is fracture of the lateral border of the scapula. So the three factors, trapezius, serratus anterior and the intact lateral border of the scapula is required for the glenoid facet or the glenoid cavity to be facing upwards. And with this, the arm can be abducted overhead. So the answer to this question number 4 is trapezius and serratus anterior acting together. Question number 5. The boxer's fracture commonly involves the following metacarpal: first, second, third, or fifth. Here you're seeing is boxer's fracture. So what is fractured in this boxer's fracture is neck of fifth metacarpal. So this boxer's fracture happens when you are hitting with a closed fist, and it's more common in teenagers. So remember that boxer's fracture is the fracture of neck of fifth metacarpal. So the answer here is D, the fifth metacarpal. Question number 6. Which of the following muscle is not attached to the proximal phalanx of the thumb? Flexor pollicis brevis, abductor pollicis brevis, opponens pollicis, adductor pollicis. All the muscles named here, they are together called thenar group of muscles. So which of the following muscle does not inserts onto the proximal phalanx of the thumb? It's easy if you think about, if you ever seen the images of attachment of muscles on the skeleton of hand, remember that the AFO together is called the muscles of thenar eminence, and that includes abductor, flexor, opponens, pollicis, brevis. These three are called the muscles of thenar eminence, which form the bulging contour over the first metacarpal, and these three muscles are innervated by the median nerve. However, adductor pollicis is a deeply lying muscle and it is innervated by the deep branch of ulnar nerve. One more important point is that adductor pollicis is the last muscle to be innervated by the deep branch of ulnar nerve. So I've added this image, that's the skeleton of hand, the palmar view, and here all the muscles getting attached, maybe origin or insertion onto the skeleton of hand have been shown, but our purpose of this image is to show you the attachments on the proximal phalange of the thumb that is in question. So why not let's zoom this out for you. I hope it's a bit better now. So as I was talking about the four muscles of thenar group, remember AFO. Now this AFO is actually abductor pollicis brevis. Remember, this is abductor, and it's easy if you remember that the purpose, the action of abductor is to pull the thumb away from the rest of the digits. Remember, abduction of the thumb is not laterally, it is anteriorly, right? Because it's at 90 degree to the plane of the rest of the digits. So abductor pollicis will be inserted onto the lateral aspect of the proximal phalange. And flexor pollicis brevis. These two muscles together, they are attached onto the lateral aspect of the base of the proximal phalange of the thumb, while on the medial aspect of the base of the proximal phalange there is attachment of adductor pollicis, right? Don't confuse with abductor and adductor. Adductor will obviously be attached onto the medial side because it has to adduct the thumb. So adductor pollicis along with the first palmar interossei, Both these muscles will be attached onto the medial aspect of the proximal phalange of the thumb, right? So two muscles on the lateral side, abductor and flexor, and two muscles on the medial side, adductor and the first palmar interossei. Remember, interossei are also meant to adduct the digits. So both of them will provide this action of adduction. So you should remember in a long time that these two will be on the medial side, adductor pollicis and first palmar interossei. And the other two, that's abductor and flexor pollicis brevis, they will be attached onto the lateral side. What remains is opponent's pollicis. Now, opponents is the muscle which has an evolutionary influence. If you think about the difference between the hand of an ape and the hand of humans, we humans have this thumb rotated medially, right? And that's an evolutionary criteria of Homo sapiens sapiens. So thumb always have this, if you let your hand set at ease, you will find that thumb does not comes in alignment with the rest of the digits. It rather is twisted medially. It is rolled up towards the index finger. And that's the reason, because opponent's pollicis, this muscle, is not reaching to the phalanx, rather is attached to the lateral side of the first metacarpal. Because of the tonicity of this muscle, opponent's muscle, which also is providing the contour to the thenar eminence, so it maintains the medially rotated position of the first metacarpal. So remember that opponent's pollicis does not reaches to the phalanx. While longus, you should always remember that longus is the term when it reaches to the terminal phalanx. So flexor pollicis longus will insert onto the base of the palmar surface of the terminal phalanx. Similarly, on the dorsal side, it will be extensor pollicis longus, which will be inserted onto the base of the terminal phalanx of the thumb on the dorsal surface, while extensor pollicis brevis will be inserted onto the base of the proximal phalange of the thumb. Another muscle, if they ask, which inserts onto the first metacarpal, and that is abductor pollicis longus. This is the muscle which is participating in boundaries of the anatomical snuff box, the anterior boundary along with the extensor pollicis brevis. So now let's summarize here. We are talking is about the insertion only. We are not talking about any origin of any muscles here. So remember, insertions on the first metacarpal, there will be opponent's pollicis and abductor pollicis longus. Abductor is at the base of the first metacarpal on the lateral side, and opponent's is along the shaft of the first metacarpal on the lateral side. Then talking about the long muscles, the longus, flexor pollicis longus, extensor pollicis longus on the terminal phalanx, palmar and dorsal surface. The remaining muscles, they will all be attached onto the proximal phalange. On the lateral edge of the base, it's abductor pollicis brevis, flexor pollicis brevis. On the medial edge of the base, there will be adductor pollicis and first palmar interossei. On the dorsal aspect of the base will be extensor pollicis brevis. So I hope it will be easy for you to remember now. 2 muscles on the terminal phalanx, 5 muscles on the proximal phalanx, and 2 muscles on the first metacarpal. These 2 are important. So answer to the question number 6 will be opponent's pollicis. Next is question number 7. Which muscle does not extend from the posterior surface of the scapula to the greater tubercle of the humerus? Choices are teres major, infraspinatus, supraspinatus, teres minor. This one is easy. I need not to add a picture for this, because SIT is a very common hit word. You must be remembering the 3 muscular attachments on the greater tubercle of humerus. SIT is supraspinatus, infraspinatus, and teres minor, right? So all the 3 muscles, choice number B, C, and D, They are arising from the dorsal surface of the scapula and reaching to insert onto the greater tubercle of the humerus. And what they have asked is muscle which does not extend from the posterior surface of the scapula to the greater tubercle of the humerus. So the answer is the remaining one, that is teres major. Because the teres major, although takes origin from the dorsal aspect of the lateral border of the scapula, but it reaches anteriorly, participating in the posterior wall of the axilla. It reaches in the front of the humerus and gets attached onto the medial lip of the intertubercular sulcus. That's why teres major is a medial rotator while teres minor is a lateral rotator of the shoulder joint. Question number 8 regarding femoral nerve. Wrong statement. You have to find the wrong statement regarding femoral nerve. First is that it runs between iliacus and psoas major, passes below the mid-inguinal point. Saphenous nerve arises from its posterior division. It arises from the dorsal division of the anterior primary rami of L2, L3, L4. This you're seeing is lumbar plexus, and this one is L1 vertebra, L2, L3, L4, L5. And these lumbar spinal nerves, they emerge from below to the numerically corresponding vertebrae. So these are the anterior primary rami of the spinal nerves, L1, L2, L3, L4. So the green color one you're seeing is femoral nerve. It's arising from the dorsal division of the anterior primary rami of L2, L3, L4. In this image you're seeing is femoral nerve, and it's descending down here between the two muscles, iliacus laterally and medially it's this psoas major, to descend down into the thigh by passing below the inguinal ligament. This is psoas major and this one is iliacus. This is a schematic way of representing the branches arising from the femoral nerve. As you can see that this line, the green, the dotted line they have shown, this line is the inguinal ligament. So there are two branches from femoral nerve arising before it crosses the inguinal ligament. One is branch to the iliacus and other is branch to the pectineus. However, this nerve to pectineus, it innervates pectineus after reaching into the thigh. Then around 2.5 centimeters below to this point from where it enters into the thigh, this point here is called midpoint of inguinal ligament. So 2.5 centimeter below to this, femoral nerve divides into its two division, anterior and a posterior division, as you can see in the image. They are splitted across to this artery, the lateral circumflex femoral artery. Anterior division descends anterior to this artery and posterior division crosses behind to this artery. So the anterior division you can see gives out these cutaneous branches. One is the intermediate cutaneous nerve thigh and the other one is medial cutaneous nerve thigh. And generally it's the intermediate cutaneous nerve thigh which gives a branch that supplies sartorius, or sometimes this branch to sartorius may be arising from the anterior division itself. Mostly it's been seen that it's a branch arising from the intermediate cutaneous nerve of the thigh. Then the posterior division supplies to the muscles of the front of thigh. These are rectus femoris, vastus lateralis, vastus intermedius, vastus medialis. The important points here is that the branch to the rectus femoris also supplies the hip joint, while branches to these vasti, the three vasti, all of them, they descend down to supply the knee joint. But the proprioceptive sensations from the knee joint are carried by the nerve to vastus medialis. One important thing is you can see that the posterior division continues as saphenous nerve, which is arising from the posterior division of the femoral nerve. It perforates the deep fascia on the medial side of the knee joint and then it becomes cutaneous. And when it becomes cutaneous, it soon gives its branch called infrapatellar branch, which supplies the skin overlying the ligamentum patelli. Then it supplies skin on the medial side of the leg, and it supplies the skin on the medial side of the foot up till the ball of the greater toe. So remember all these important points, and remember that saphenous nerve is a branch arising from the posterior division of femoral nerve. Now, important points here in this image, the terminology regarding this inguinal thing. One is ASIS, anterior superior iliac spine, and the 2 points here. One is pubic symphysis, right? This medial most surface of the pubic bone which participates to form this secondary cartilaginous joint called the pubic symphysis. This upper surface here, this surface is called, the red thing I have drawn here, this is called pubic crest, and there is a prominence here, the protuberance here lateral to the pubic crest is called the pubic tubercle. So the two terminology, from ASIS to the pubic symphysis, the line or the fold created when you completely flex the thigh, right? So complete flexion of the thigh is when the front of thigh touches the front of abdomen. That happens when you're sitting in a squatting position, and that fold created is called inguinum. So the midpoint of inguinum will be somewhere here, and this point will be called mid-inguinal point. If it's asked what structure passes below the mid-inguinal point, then you'll say that it is the femoral artery that passes below to the mid-inguinal point. Then you're seeing is another structure that is in green color. From ASIS till pubic tubercle, there is a ligament. This ligament has a slight convexity downwards, and this is called inguinal ligament. So there will be a point somewhere here. This point will be called midpoint of inguinal ligament. Remember that 2.5 centimeter above to this, there will be a ring, evagination of the fascia transversalis, and this is called deep inguinal ring, around 2.1 centimeter above to the midpoint of inguinal ligament. One more structure that lies outside the femoral sheath, that's the structure we are discussing in the question, and this structure is femoral nerve. Femoral nerve runs outside the femoral sheath. Femoral sheath is a continuation of fascia iliaca posteriorly and fascia transversalis anteriorly into the thigh. That sheath has three compartments. Lateral compartments is femoral artery that passes. Middle one is femoral vein, and the medial one is called the femoral canal, where you find is the lymph node of Cloquet or Rosenmuller. And here there will be rounded horizontally placed ligament called the lacunar ligament. The important point here is that femoral nerve you are seeing is also passing below to the midpoint of inguinal ligament. This is another image explaining the same thing. Here it is ASIS, here it's pubic symphysis, here you have pubic tubercle, and the line joining ASIS to pubic symphysis is called inguinum. The fold created when you completely flex the thigh, and from ASIS till pubic tubercle, here this ligament is the folding of the aponeurosis of external oblique abdominis, which is slightly curved downwards, convex downwards because of the pull from fascia lata. This is called inguinal ligament. So this will be the point here, the midpoint of inguinal ligament, and here it is the mid-inguinal point. So you can very well appreciate that which point will be medial and which will be lateral, because lateral point of both the things is the same. The lateral point is ASIS, but medially there are two different points, pubic symphysis and pubic tubercle. Obviously, the line which is longer and reaching more medially is the inguinum. So the midpoint of inguinum, mid-inguinal point, will be medially placed, while this inguinal ligament is actually a little shorter than inguinum, because pubic tubercle lies laterally to the pubic symphysis. So midpoint of inguinal ligament will be a little lateral to the mid-inguinal point. Here also you can see in a lateral image, where you're seeing is this space called the acetabulum. Here it's pubic tubercle. Here it is ASIS, and this is the inguinal ligament. This is iliacus muscle. This is pause. And I have taught you before that this nerve, femoral nerve, you can see is this. This is descending down between iliacus and psoas major, and it is running outside to this sheath. This sheath you are seeing is called the femoral sheath. Femoral nerve is running outside and lateral to the femoral sheath, below to the midpoint of inguinal ligament. And this is femoral artery. This femoral artery is running in the lateral compartment of the femoral sheath below the mid-inguinal point. So the answer to question number 8, the wrong statement is that femoral nerve runs between iliacus and psoas major is correct statement. It passes below the mid-inguinal point. Now this is going to be a wrong statement because you know that femoral nerve passes below the midpoint of inguinal ligament. However, saphenous nerve arises from its posterior division is correct. Arises from the dorsal division of anterior primary rami of L2, L3, L4 is also correct. Now question number 9, lumbar plexus. You have to tell the wrong statement regarding lumbar plexus. Ilioinguinal nerve, L1 ventral division. Genitofemoral nerve, L1, L2 ventral division. Accessory obturator nerve, L2, L3 dorsal division. Obturator nerve, L2, L3, L4 ventral division. So you just have to tell that which nerve is written with its wrong root numbers. Now here you're seeing is lumbar plexus, and these are the anterior primary rami L1, L2, L3, L4, L5. These are the anterior primary rami of these spinal nerves. And here I'm going to draw is the ventral divisions and here the dorsal divisions. From L1 you can draw two nerves like this, then you can draw another image like this, and now you can draw like this. So L1 ventral division, this is ilioinguinal nerve. L1 ventral division is iliohypogastric nerve. L1 L2 ventral division is genitofemoral nerve. And remember, this lumbar plexus, the roots, remember, they are buried under the substance of this muscle psoas major. So all of them, these nerves, they emerge on the lateral border of psoas major, between psoas major and quadratus lumborum. But genitofemoral nerve emerges after perforating this muscle psoas major onto the anterior surface of psoas major. Genitofemoral runs or descends onto the anterior surface of psoas major. Then L2, L3 dorsal division, this nerve is lateral cutaneous nerve of thigh. L2, L3, L4 ventral division, this nerve is obturator nerve. L2, L3, L4 dorsal division, this nerve is femoral nerve. L3, L4 ventral division, this nerve is not always present, and this nerve is accessory obturator nerve. Hope you have learned the root numbers of all these nerves here. So coming back to question number 9, ilioinguinal nerve L1 ventral division is correct. Genitofemoral nerve L1 L2 ventral division is correct. Accessory obturator nerve L2 L3 dorsal division, no, this is wrong because it arises from L3 L4 ventral division, and obturator nerve L2 L3 L4 ventral division is correct. So you got your answer here. The answer is C. Last question, question number 10. Which nerve does not make contact with the periosteum? The nerves are radial nerve, axillary nerve, median nerve, ulnar nerve. Now because these nerves are the nerves of the upper limb and in the arm, so we considering that they're talking is about the periosteum of humerus. I have made a video, small video, short video of around 3-4 minutes. You can watch it. I have attached the link. So just remind you once again here that radial nerves runs in the radial groove. Axillary nerve runs along the posterior surgical neck of the humerus. Ulnar nerve passes behind the medial epicondyle of the humerus. So these three nerves are in intimate contact to the humerus, to the periosteum of the humerus. So the answer to this question will be median nerve, C. So that's all. Good luck.